Okay, I'm glad I have a little bit more time for this one because I put in a lot of content. So feel free to let me know if you have any questions as I'm going through. But like Dr. Brown said, I'm going to be going through an overview of fetal alcohol spectrum disorders in the adult population. So I won't be talking about pregnant women using alcohol. This is for people who are adults and may or may not have a diagnosis of FASD or fetal alcohol spectrum disorders. Okay, so I want to clarify the terminology. When I say FASDs or fetal alcohol spectrum disorders, this is an umbrella term. This is not a diagnostic term. So this umbrella term describes a range of effects that can result from prenatal alcohol exposure. So in the US, you wouldn't say I have FASD, you would say I have one of the FASDs. And I'll get into the different diagnostic terms in a second. So you might commonly hear fetal alcohol syndrome, which is a medical diagnosis, and it's usually made by a physician. So FAS is one of the FASDs. So here's the full umbrella of FASDs. Like I mentioned, we have fetal alcohol syndrome. We have partial fetal alcohol syndrome, or PFAS. We have alcohol-related birth defects, or ARBD. And we have alcohol-related neurodevelopmental disorder, or ARND. And you'll notice FAE, the fetal alcohol effects, that's more of an outdated term. You don't see that here. So this is the most updated terminology in the US. I did include two things that you might see in the DSM-5. Neurodevelopmental disorder associated with prenatal alcohol exposure. And I don't know too much about the criteria, but I can always look that up later if you want me to. But I want to include that because you might see that in the DSM-5. So when we're talking about alcohol in pregnancy, I just threw on some statistics here. We know that about 1 in 20 pregnant women drink excessively before finding out they're pregnant. 7.6% of pregnant women use alcohol and 1.4% binge drink. We know that there is no known safe amount of alcohol or safe time to drink alcohol during pregnancy. And I want to highlight the word known because there are many people that do consume some amount of alcohol during pregnancy and do not have a child that's born affected by the prenatal alcohol exposure. So we know that it's not a guarantee. If you drink 1 sip of alcohol, your child will have one of the FASDs. We just don't know that specific safe amount of alcohol or when it might be safer to drink alcohol during pregnancy. We do know there's a wide range of disabilities due to prenatal alcohol exposure, from mild to severe. So this also goes into the umbrella, that umbrella visual. In addition to there being those 4 different diagnostic terms, there's a variety of disability that can occur within those terms. So it truly is a spectrum. And we do know that of all drugs of abuse, alcohol causes the most serious and the most long-lasting neurobehavioral damage. So I put this graph up here. I always like to use this, it's helpful to visualize. So this is the span of fetal development. And the red lines are where major congenital anomalies can occur when the fetus is exposed to alcohol. And then the yellow is minor congenital anomalies. And I'm happy to send this to anyone after this presentation too, if it's hard to see on your screen. But I wanted to highlight is essentially from 3 weeks to full term, using alcohol can impact the developing fetus in different ways, whether it's the heart, the central nervous system, the eyes, the ears, etc. This is just a good visualization that after 3 weeks, alcohol will affect the developing fetus in these different ways. So in terms of incidence and prevalence, we know that the range of FASDs are more prevalent in both autism spectrum disorders and Down syndrome. We know that studies using in-person assessment of school-aged children identified 6 to 9 out of 1,000 children with FAS. However, that's, again, fetal alcohol syndrome, and we consider that to be the tip of the iceberg. So the estimated range for the full range of FASDs that I mentioned are as high as 24 to 48 out of 1,000 school-aged children, or approximately 2.4 to 4.8% of the population. And that was found in a study from 2014. I think that's our most recent data on the prevalence. So higher, much higher than FAS. The majority are undiagnosed. probably the vast majority are undiagnosed, and I'll get into that a little bit later as well. So individuals affected by prenatal alcohol exposure can have a range of serious lifelong problems. This affects a lot of life components, including physical, cognitive, behavioral, and social deficits. And I know we're talking about adults, but I really found this image to be helpful. This is the same individual. This is from a study in 2015 from the University of Washington. The same individual at age 2 on the left and age 20 on the right. And this person presents with the 3 characteristic facial features of fetal alcohol syndrome. And I'll get into that in a second too, but you can notice small eye openings, smooth philtrum right here, and a thin upper lip. And I'll get into that in a second too. But it's helpful. I've had requests for people to see real people with this diagnosis versus a cartoon image, so I included that for that reason. So in terms of the diagnostic criteria for fetal alcohol syndrome, the effects of alcohol on the developing fetus depend on the timing, the amount, and the frequency of alcohol consumption, like I referred to in that previous graphic. So in terms of what's required to confirm a diagnosis of FAS, those 3 specific facial features, which I mentioned, small palpebral fissures or eye openings, smooth philtrum, the space between your nose and your upper lip, and then a thin upper lip. So those are the 3 cardinal facial features. Growth retardation, either in height or weight, and then central nervous system abnormalities, for example, a reduced brain size. So one important note here is that a documented report of prenatal alcohol exposure is not required for a diagnosis of FAS. So for example, if you're working with someone who was adopted and they have no information about their birth parents and what their birth mother might have consumed during her pregnancy, that information is required to confirm a diagnosis of FAS. So here's the more cartoon type image showing those 3 cardinal features. This also includes a short nose, which is common but not required in the diagnostic criteria, and a flattened midface. Again, common but not required in the diagnostic criteria. Again, I know this is a young child, but the facial features typically remain somewhat the same through adulthood. So with partial fetal alcohol syndrome, this is where there are 2 or more of those specific facial features that I mentioned, and one of the following. So pre and or postnatal growth retardation, evidence of deficient brain growth or structural abnormalities, and then evidence of cognitive or behavioral abnormalities that are inconsistent with the developmental level and that can't be explained by genetics, family, or environment alone. Similarly, a documented report of prenatal alcohol exposure is not required. So this is very similar to FAS, but they just may not have all of those facial features to qualify for the full diagnosis of fetal alcohol syndrome. Next is alcohol-related birth defects, or ARBD. This does require confirmed prenatal alcohol exposure, which can create difficulty if we don't have information about the birth mother's alcohol use. It requires 2 or more specific facial features, same ones that I mentioned, and at least 1 associated congenital structural deficit, for example, supination, pronation of the wrist and forearm. I think this is the most rare of the FASDs. This is essentially where the physical features are impacted, but the brain and the cognitive functioning might not be as impacted, and I think because the brain is impacted so long throughout the pregnancy, I think this is the most rare. I have never seen it personally. The most common one that I've seen is alcohol-related neurodevelopmental disorder, which is pretty much the opposite, where there might be pretty significant cognitive impacts, but the individual displays no physical features. It truly would be a hidden disability. This also requires confirmed prenatal alcohol exposure, which complicates the diagnosis, like I said, and also might be one of the reasons that the majority of individuals with one of the FASDs are currently undiagnosed, because the lack of that information makes it difficult. But it does require at least one of the following: evidence of deficient brain growth or structural abnormalities, and or evidence of cognitive or behavioral abnormalities, again, inconsistent with the developmental level that can't be explained by genetics, family, environment alone. So again, this is the most common one that I've seen. So in terms of what brain structures are particularly affected by prenatal alcohol exposure, we do know that it affects all regions of the brain. However, there are some areas that are particularly susceptible. This includes the corpus callosum, which is the communication between the two hemispheres of the brain. The frontal lobe is a big one that controls the emotional responses, processing of humor, expressive language. It's responsible for abstract thinking, and it's involved in processing information and deciding how to act. We know the hippocampus is affected, which involves learning, memory, and emotion, and the amygdala, which is involved with fear, stress, anxiety, anger, and aggression. So this was a good way to highlight how it really can have a large impact across a person's life. Going a little bit more into cognition, we know that prenatal alcohol exposure can affect specific learning disabilities, poor academic achievement. You can see a discrepancy between verbal and nonverbal skills, and you might see slowed movements or reaction to people and stimuli. In terms of executive functioning, you might see poor organization and planning skills. Concrete thinking is a big one. Lack of inhibition and poor judgment, again, that's related to the frontal lobe impacts. Inattention, memory problems, and hyperactivity. In terms of motor functioning, you might see delayed motor milestones, clumsiness, some balance problems, tremors, and poor dexterity. Social skills is also an area that can be pretty significantly impacted by prenatal alcohol exposure. So you might see a lack of stranger fear. That's probably more applicable for younger individuals. A vulnerability to being taken advantage of, social immaturity, superficial interactions, sometimes an inappropriate choice of friends, and then increasing social difficulties as the person ages, and sometimes a difficulty comprehending someone else's feelings or putting themselves in someone else's shoes. So here are some common co-occurring disorders with FASD. Sensory integration disorder is a big one. I've seen that one a lot co-occurring with FASD. Reactive attachment disorder, attention-deficit hyperactivity disorder. Some individuals also get mistakenly diagnosed with ADHD when it's likely an underlying FASD. Traumatic brain injury, borderline personality disorder, depression, and substance use disorders. Like I mentioned, some possible misdiagnoses for individuals with FASD includes ADHD, oppositional defiant disorder, and conduct disorder. Those are pretty frequently given when likely there might be an underlying FASD as well. So in terms of working with individuals with FASD, providing structural support can be very helpful. So that would include providing consistent routines and consequences. So consistently repeating, if you do X, then Y will happen, and really laying that out. Providing frequent and short breaks. Modifying time frames, so this means an increased time for any transitions and changes, and an increased time to process and think and respond to questions. Both of those are really important. And also the concepts of dependency and enabling its negative terms should be reconsidered with this population. So for example, taking someone to their appointment, checking on them regularly, helping them filling out forms may be exactly what they need in terms of structural support. Some educational strategies when you're working with someone with FASD, it's helpful to use short and simple sentences, teach one concept at a time, and help support memory strategies if the concepts you're teaching are something they should remember in the future. Like I mentioned previously, using concrete language is really helpful, and refrain from using abstract language and idioms. I've made that mistake myself. That's a really helpful one. Asking the client to repeat information they just heard. However, a caution here is that with FASD, a higher verbal IQ than overall IQ is common, so they might be able to verbalize a concept without being able to fully understand it and then also generalize it in environments in the future. And as always, repetition is really helpful. Don't assume they remember what you talked about yesterday. They might and they might not. So it's helpful to just do a quick reiteration of what you talked about last week or even last month, especially the longer time goes by. It's helpful to repeat information. In terms of counseling, it's really helpful to focus on social skills, since, like I mentioned before, this is an area where many people with an FASD can stumble. It's helpful to consider the insight of the client versus their actual behavior. So an example of this is concrete counseling, and concrete techniques in counseling are usually going to be more helpful compared to insight-oriented counseling. We know that motivational interviewing, for example, is pretty abstract as a counseling technique and may not be as effective with people with FASDs. And of course, modify your counseling to accommodate the cognitive disability. Individual rather than group counseling can be helpful, at least at first. And then, as always, provide reminders for upcoming appointments, even the same day if that's possible. That could be very helpful too. It's helpful to assist clients to identify issues of importance to them. Don't expect generalization. So if you go through a concept in one environment, help teach them in real environments to generalize that concept. This might require field trips to home, work, or their community. And don't use examples that aren't relevant to the client. This kind of goes into talking about more abstract concepts. If what you're trying to teach or work with the client on isn't relevant to them, it's likely not going to be as helpful. If you're seeing any behavior that needs to be directed, such as anger, frustration, or overstimulation, that's okay. Acknowledge it and redirect it if necessary. If possible, limiting staff changes is helpful. And of course, it's life, so when they do occur, prepare the client for those changes ahead of time and then throughout the transition as well when they do occur. If you joke with a client, let them know that you're joking and point out when others are joking as well. This helps build that social skills component. Some approaches to assist with modifying behavior. It's helpful to remember that behavior you're seeing might be related to or exacerbated by a lack of sleep and sensory difficulties, like I mentioned previously. It's really helpful to use multiple senses, such as touch, smell, and sound, in addition to just verbal approaches. So art therapy is an example, or even having the person you're working with doodle while you're talking to them, that can be really helpful. Designating a mentor for the individual to go to when they have a question or they don't know what to do in a certain situation. This is really helpful, especially for adults with one of the FASDs, to increase quality of life and functioning throughout adulthood. In this relationship, role-playing situations and modeling behavior can be very beneficial. So if consequences do need to be used, they should be immediate, related exactly to what occurred, and finished preferably within the same day, just to keep it very relevant to the client that you're working with. And anytime you tell someone you can't do this or even recommending against doing something, it's extremely helpful to replace that with what they should be doing or what they can't be doing. And just let them know this is what you could do or should do moving forward. So I know that was a lot of more discouraging information, but I do really want to emphasize that it's super important to identify the strengths, the abilities, and work to build upon them when you're working with people with FASD, and they do have a lot of strengths and a lot of great abilities. So I wanted to end my presentation with emphasizing this. It's really helpful to point out small accomplishments frequently and consistently work with the person to communicate what they're doing well and what they're good at to build upon their successes. And the majority of the information I got from for this presentation are from these two sources, and I can always connect you with more resources if that's helpful too. I think that's it. Yeah. All right.
Great, thanks, Lindsey.
Yes.
Any questions or comments? You know, in the context of, you know, and I don't work in a specialist treatment organization currently, so excuse me to those who do if I'm mangling this. But, you know, frequently as you're going through a program like intensive outpatient, I mean, information is getting presented that sort of builds as they get so far as, you know, building coping strategies and things along those lines, identifying triggers, strategies. I wonder if you could talk a little bit about kind of those specifics and how you might think about how the plan might be modified to feed into what you've been telling us about.
Definitely. I think the biggest thing, and I'm not sure how a lot of organizations do it, but having that written down, even working with the client to write that down, like if you're coming up with triggers, have the client write them down themselves to really engage them in that work rather than more so handing them information and then talking about it. That can be helpful, but it's always helpful to have those backup connections to different sensory components, even doing things auditorily. Some people might find that helpful and some not. So connecting music in some type of way to engage senses in that way, that can be helpful. And there was another part of your question I wanted to address. If possible, I know it's hard, but just limiting the amount of information that you're providing at one time. If you're able to, I know there's time constraints and everything, but if you're able to break it down really as much as possible, I think the more you're able to do that, and depending on the diagnosis, of course, and the level of functioning, the more you can break it down and simplify things and truly make it relevant. So when talking about coping skills, exploring what's worked for them in the past, rather than offering some skills that might not be helpful for them at all, or they might not even understand what that means. So kind of exploring maybe what's already worked for them before and using what is the most applicable and relevant to them. And then writing it down, providing it for them when they come back the next time, and just really building upon that. And repeating that again. So not assuming that the trigger you identified last week, that they're going to remember what that was this week. So documenting that and having the client kind of integrate that would be really helpful too.
This is Sheila with a comment and a question. So in response to what you were saying, we've had good luck with using the matrix materials, particularly the early recovery skills pieces. They're very, as you described, very concrete. You go through things again. There's a standard structure to it each time, and people can build on it. We have them bring those back and we work with them. So that's worked well for us. My question is, do you have numbers on, because we know that substance use disorder is more common in people who already have this exposure. So do you have the numbers on what the incidence is in the population that is diagnosed with a substance use disorder?
That's a great question. So in terms of people who are diagnosed with substance use disorders, what percentage of that population has a diagnosed FASD?
Yes.
Great question. I'm gonna look that up for you.
Or maybe an undiagnosed, I mean.
Or maybe undiagnosed.
Yeah.
We have a sense that we're seeing a lot.
Yeah.
And so I've had one person trained as a screener, but this is one of our areas of further development. In fact, I appreciate the resources. I have a couple of patients at different sites that are struggling, and really what the issue is exactly what you just talked about, but people are not seeing it in that way.
Yeah.
So in order to help staff see, and where possible, actually that we're able to identify. Because in some cases, it's going to help them access other funding streams and things. But really being much more plugged into that.
And I like to look at it as, thank you for sharing that, acting as if, if we maybe think that this is something that a person's struggling with, but they don't have a formal diagnosis, even if they don't have one of the FASDs, it's not going to harm them to use more concrete language skills, breaking things down, making things simple. Really that would help anyone with or without a cognitive disability. So that's kind of the phrase that I've used, act as if you're not sure, and implement.
Where they get into difficulties, it tends to be in more of those follow through things, and people becoming frustrated with those things. And not recognizing how sometimes the environment alone is overstimulating and why people are struggling. So those were the elements that we were wanting to pull out and work on a great deal more. So excellent.
Yeah, thank you for your comments.
We actually had a question in the chat field too. How important do you feel it is to have the diagnostic label applied, as opposed to using appropriate strategies, worry about alienating or scaring off the mother who is also my patient?
Great question. You hit on like one of the main concerns within this field. In terms of the first question, I think that depends more so on what the individual is struggling with. So I've experienced some individuals, I know one that wasn't diagnosed until his 40s, and the amount of reassurance and relief that it provided for him, knowing like there's not something wrong with me. This is something that I've been dealing with my whole life. It's not just me. Was really helpful for him to have that label associated with who he was. He found it to be very helpful. However, on the other hand, I think you're getting at a huge piece in terms of stigma associated with the FASD label, and then in terms of the birth mother, especially if that's your patient or your client. So I would say it's definitely helpful to just use appropriate strategies. If the family isn't interested in pursuing a diagnosis, I definitely wouldn't push it, as long as you can still implement those techniques that you think might be helpful. And if you're concerned at all about it alienating the mother or the family, I would probably roll with that and do what they're the most comfortable with. You can always bring it up and in a non-judgmental and non-shameful way. This might be one of our concerns. We're just hoping to build upon what supports already exist and what your child is already good at. And then we just want to help them in the future. Usually looking future-oriented is helpful rather than focusing on what was done in the past. But I would say really just letting the client or the family kind of lead in terms of if you bring up the conversation, see how they react to it, and go from there. And if they're not interested or if it's emotionally difficult, then maybe just talk about implementing those different strategies that could still be helpful.
This is Ritu. Sheila also, I think, mentioned about whether there are separate funding streams related to the diagnosis. I wonder if you can speak to that, because that would be the only benefit I can see of actually having that diagnosis applied, especially if, and I think there actually, it can be presented to the patient who's the mother in a way that she's probably struggling with some of the behaviors of the child, and if she can understand that it's not about blaming her, but rather about giving her the tools to be more effective in communication and interaction with her child, and for that child to be successful, then it can be presented in a also present-focused manner too. Yeah,
absolutely. I do know that previously I've helped a couple individuals apply for Social Security benefits using this as a disability and was successful. So that's something to consider. I'd have to look a little bit further into additional funding streams, but that is one example that I have had success with.
And I was primarily leaning towards that because sometimes there will be access to additional training and other resources to help the person move forward in education and career. So it can be very helpful.
And one thing to note is a lot of interventions or treatments for different types of cognitive disabilities are specifically not helpful for people with FAS, one of the FASDs. So that's really important to keep in mind, that it's not just, well, they have some type of cognitive disability, so we'll just try what we think works for cognitive disabilities. FASD is pretty unique, so that is one additional reason that it would be helpful to have a diagnosis for FASD, because it really does involve some specific considerations.
I was going to ask the same question about funding streams. I was curious, like, what your experience with opening up financial or resources was. Have you ever been involved in a diagnosis of an adult who then it sort of creates family problems where they're rejecting their family or have anger towards their family?
Most of what I've seen is there are already family problems. Yeah. It's not,
this is a new cause.
Yeah, it's not like everything's perfect and happy, and then this caused a lot of turmoil. I think typically there already is a lot of turmoil.
And where do you work?
Or how do you have? Yeah. So previously I worked in this department on several different research and outreach projects surrounding FASDs. Okay. So in multiple different sites, multiple different ways, like with prevention, identification, treatment, and referral. Okay. Like 3 to 4 different projects. Okay. So that's kind of where that comes from. Okay. Yeah.
And I would just piggyback on, we've had similar experience in that some people we have helped work through being evaluated and things. It was much more the relief of the individual. They didn't know why they had struggled.
Yes.
They weren't a bad person.
Mhm.
They just felt like they had tried and couldn't do it, and somehow they were failing.
Yep.
So having an explanation made it much easier to then develop a plan and move forward, and it helped with self-esteem and some other things.
Yeah. Thank you so much for sharing that. That is the majority of my experience too, is that it provides that feeling of relief.